Well, great. Hey, everybody. I'm Nina Crowley, Seeka's Professional Affiliations Manager, and I'm here today to talk to Jennifer Clements, a pharmacist in the area of obesity medications. And she just got back from speaking at the AACE meeting of clinical endocrinology out in Seattle. And she did a talk that I really was hoping she could come talk to me about. So your talk was about a one-size-fits-all approach, clinical pearl, or one size does not fit all, rather, clinical pearls with medications for weight management. And so when I saw that you were speaking there, I dove in a little further and realized that you're also in South Carolina. So I figured that we had to connect. And thank you so much for coming on and talking with me today.
Yeah, thank you for having me.
So first I'd love to hear a little bit about your background and how you're connected to the field of obesity and, what kind of work you do. And then maybe you can talk to me a little bit about how that meeting went and specifically how your talk was.
Sure. So I am a pharmacist and been a pharmacist now for 17 years. And after residency training, really was developing clinical pharmacy services with chronic disease state management. And a lot of that was around diabetes. And it probably with weight management, it really started when I was practicing in a rural health family medicine clinic, and I was getting internal referrals to assist and help individuals, both pediatric and adult, in terms of helping them lose weight. And so from those internal referrals, I actually did a prospective type of study, really looking at more of my role as a health coach, because in a rural health family medicine setting, it was difficult to recommend an anti-obesity medication, just given that about 80 to 85% had Medicaid and Medicare. So the cost of the medications were extremely high and they wouldn't be able to afford them. And from that particular study, it was 6 months, but I was able to show that even just providing lifestyle modifications and guidance and a monthly approach led to more weight loss than those that didn't enroll. But from there, I also have done a lot more educational stuff around weight management, particularly at one of my employees or institutions, adding it to the pharmacy curriculum, really promoting that we educate pharmacy students, given that the number of anti-obesity medications have increased, and therefore they should be knowledgeable about them because they're going to be verifying prescriptions and providing education on them. But I've also done a lot of education, more continuing education for pharmacists on a state level, national level, because I feel like this was something not in the curriculum when I was a pharmacy student. And I think we're going to be seeing a lot more medications. And some of that evidence is already out there for like phase 2 or phase 3 studies. So we really need to be talking about it and knowing that one size does not fit all. And that's really where I'm very fortunate that the Endocrinology Association was able to allow pharmacists to come and talk on this particular area. So Diana Isaacs and I really covered a brief review of the current medications that are available, kind of comparing them in terms of mechanism of action, contraindications, pharmacokinetic profiles. Really wanted to provide an overview from a pharmacist perspective. And then we really went into cases because we wanted to really talk about some real life scenarios that we have encountered. The one that I focused on was more related to cost, more than anything, where an individual would not be able to afford an anti-obesity medication and trying to be creative and think outside the box. And then my co-presenter, Diana Isaacs, provided cases more around using semaglutide and then tirzepatide, even though that's off-label. In terms of the weight loss, it's not approved for that yet. So she more covered cases using both of those medications.
Okay. Well, I love the idea, first of all, of, including pharmacists on the team, since it's just interesting how that has not been part of it with all of the organizations that I've been part of. We've had a few, and it's, I think, a valuable position that we really should expand more of. And the coaching that you can provide, I think that's so valuable, especially when we're talking about the nuances. I mean, at the pharmacy, I think that's probably one of the things I hear providers talk about the most is how to get it in their hands. And so that's huge. So, um, any feedback from the meeting or any conversations that you had, around that? Or if you want to talk about some of the access to care, that's a big passion area for me. I know we really see finally some effective medications, and now it's really hard to get coverage for them. So that's very frustrating for everybody.
Right. And after the presentation, we had a really good response, a lot of positive feedback on one, our role as pharmacists and how we should have a greater role within this particular area. And I do think that could span on multiple levels, especially for community-based pharmacists where they are probably located even in rural areas as well. And people are still getting their prescriptions. How can we elevate them to provide even some additional education, even with medications that they may be taking for whatever reason and indication? But we did have a lot of positive feedback. A lot of it too was really based on how we may be recommending certain medications and also deprescribing other ones. So
Mm.
when adding on semaglutide or tirzepatide, if someone's on basal insulin, how we may be decreasing that over time to reduce the risk of hypoglycemia, but also they're losing weight, so therefore they're at risk of hypoglycemia. They're hitting their targets more, and with the use of diabetes technology like CGMs, you would be able to note that. So how do you back off? So we really just received a lot of feedback on that. But yes, with affordability, I think we didn't want to open up a can of worms, especially with my case. But being that it was case-based, we had some options for questions. And I know for the last one, I did throw out there more kind of unique regimens just to get people thinking, but also could not really dive too far deep into that. And some of it was related to what we've heard with compounding pharmacies making compounded semaglutide. And I know that some people are utilizing that for their patients because they can't afford the brand name product. And I know that is more maybe ethical considerations. In the area of weight management, but I know that the
Huge hot
compounded
topic.
formulation may be cheaper than what the brand name product is. But that's always something we have to consider with new medications is that they are going to be expensive. And how can we get someone to be able to afford that, especially because we know weight management is probably something long term, even though studies are 2, 3 years in length. We know we need to be looking at this long term.
Yeah. Well, I'd love to pick your brain about the compounding piece of that because, what I'm seeing a lot of our healthcare providers talk about is, of course, we don't know what's in the medication if it's in that realm. I know a lot of people have trusted compounding pharmacies that they go to, but there's also a lot of out of state mail order type stuff going on, and I think from the providers side, there's a lot of concern. But then, yeah, from the patient side, there's a lot of this is what makes it so hard, right? Like we finally have a medicine that's highly effective, and people are desperate for help, and they haven't had an option for so long. So, how do we navigate that efficacy or safety component of that?
Yeah, I think it's a hard one because with the compounded product, if it's an injection, I know that they're adding to make it different, adding vitamin B12 or L-carnitine to it to make it different. But then I don't, you kind of have to wonder where are they getting the semaglutide to even compound it. And it's not what was studied. I mean, that's the thing is when I talk to a patient or any person with a chronic disease state, I want to provide the evidence. Well, I know the evidence with the brand of semaglutide that's out there, but this isn't the same thing. This is not what was studied in all of those clinical trials. And I think that's what makes it difficult. I also know that some compounded pharmacies are making tinctures out of semaglutide, really with the ribelsis, and using that particular product to make those at doses that may be similar to like Victoza, so the 0.6, the 1.2, and the 1.8. But again, it's like when we're talking evidence and we're trying to tell an individual, like, this is what the studies say, this is the average weight loss, these are the adverse events, it's not what was studied. And so I think it brings up a lot of ethical and even legal considerations, because we're now seeing boards of pharmacy in certain states come out with guidance or statements about this because they know it's an issue. Nova Nordis also has come out with their statement about it because it's their products. And also, we know that people get medications from other countries, and those countries may also try to be cutting or cracking down on that type of method to get the product. And so I think it's just causing a lot of probably backlog in different areas. We clearly know that the demand is there for these products because of how effective they are, but we still need to make sure that it's a safe product for someone to take and that we know it's truly what was studied.
Right. I can just imagine how hard it is when you realize I mean, you need help, you want this product, you don't have coverage, you don't have, $1,200, $1,300 a month,
Mhm.
and here's an option. And, if it's from a trusted healthcare provider, if your doctor's prescribing it, I can see where that would feel okay to do. And I don't know that we've seen really the outcomes of that, whether that be weight loss or any, serious events. Have you heard anything like that? Like,
No,
is the
I
weight loss
haven't.
different? Are they having
No, because I
scary
think,
events happen?
yeah, I mean, I think there's various clinics that are using it, and they may follow up with their patients a little bit more frequently than other clinics or even in like primary care, just given that they know it's compounded and they want to be able to see if there are any safety considerations. So these also may be different types of clinics, maybe like a concierge type of service, or one where maybe they pay cash, because those patients are willing to do it at a cheaper price. So I'm sure that maybe their frequency of follow-up is a little bit different than a regular primary care clinic. One thing that what I would like to see is more healthcare systems and also insurance companies really focus on obesity as a chronic disease state, as we know the AMA has stated that it is, because there is evidence to show when you kind of invest in it and cover those anti-obesity medications, you can prevent or you will see cost savings long term. And so I think that's important. And some of that may even be starting with employees, because we have large healthcare systems and these medications can go on the employee plan, and you can start there to show the benefit before expanding out. Or that's just more justification for payers to invest in coverage for these anti-obesity medications.
I would love to see that. I mean, we had a little bit of good news with the federal employee program having coverage. I know we've been talking about Medicare and anti-obesity medications for 10 years at least with the Treat and Reduce Obesity Act. So it's kind of an exciting time. I know people who've been in the field a whole lot longer have seen things come and go. I've heard a lot of people talk about it almost like they did with cholesterol medications or even antidepressants over the years, where we have this sort of weird time in the beginning where it's not covered and it's expensive and there's access issues and there's safety and all of that. So, I think people who've done the long haul can say this will follow some sort of maybe predictable curve. But I completely agree with you in that the thing that seems so different about obesity medications is that we have this sort of not recognizing it as a chronic disease, having bias, and kind of suggesting that people do diet or exercise instead of it being what we know it needs to be, which is comprehensive and layered and driven by intensity and severity of the disease of adiposity. So I do think it's different in that regard, but I do hope that we're able to see the supply issues get resolved. We could probably talk again about all the media coverage and how kind of wrong they've gotten that. But, and then the safety and the compounding stuff has been another one. So luckily I've seen a lot more of my colleagues on, radio or podcasts and doing news articles and things about this to try to correct some of the misinformation. So hopefully we're getting some good information out there to people about the right kind of patients to take this and for lifelong. I mean, that's another piece of this, right? Where, people say, well, just, take it until you lose weight and then get off of it. And so I think, like you probably do this every day, talk to folks about, if your medication's working, you take it forever. For the most part, that is what we really want to promote as we're talking about it as a chronic disease.
Mhm. I agree.
Well, thank you so much for your time today. I feel like we could definitely dive in and talk a little bit more about some of these medications and how they work. So I may be reaching back out to you as we see more come down through the pipeline. I think that's another really exciting thing after being in the field for 17 or 18 years myself. We had a real stagnant time where that treatment gap between folks who could, lose enough weight with diet and exercise. And then on my other side, the surgery side, there was just a gap in between. So the medication part of the pipeline is really finally coming into that spectrum of care, which I think is really exciting.
Yeah. Well, thank you for having me.
Great. All right. We'll talk to you soon and maybe see you at the next local meeting here in South Carolina.
Yeah.